Welcome back, guys. Part 10 here of the 12 lead series, and we're getting there very slowly. I know. This one here is kind of the important part. Way back when, video number 1, I said, hey, one of the things that we use a 12 lead for is to know whether or not we have VTAC. So we're going to talk about the wide complex tachycardias and why they kind of throw lumps into here, and how we can use the 12 lead to determine where that wide complex tachycardia is coming from. All of a sudden now, does it change our treatment modalities? The answer is yes, yes, very much yes, and yes. Okay. So let's figure out what it does. Okay, how to identify VTAC from SVT. Okay, and that's the real reason that we're doing this. Okay, misdiagnosing wide complex tachycardia. You can have some major issues because of that. All right. So the pitfalls with it, we rely on lead 2. So it comes to the question of V2 is actually probably, for telling whether or not you've got ventricular tachycardia, is probably the worst lead that you could possibly use. Okay. And why is that? I'm glad you asked. Well, the reason that it's the worst one that you could possibly do is, remember that a ventricular rhythm, right? Lead 2 is looking at that 60-degree angle on our hexadecimal system. Okay. Here's the problem, gang. If it's a ventricular rhythm, it's going to start here and it's going to go that way. The exact opposite of what it should be. Okay. Or it could be down here and go that way, or kind of there and go this way. Long and the short, though, you end up in that no man's land out here. All right, that's where you're going to end up at. All right. Now, what about this guy right here? Let me erase my. Now that I've made a total mess here. Atrial fibrillation. Usually, what happens if it's atrial fibrillation, or if it's something with a left or a right bundle branch block. Okay, how do I know whether or not it is the SVT with a bundle branch block versus actual ventricular tachycardia? Do I treat them different? Yep, I sure do. Okay, so I have to know, I've got to be able to look at it. Now, by the way, first and foremost, and I have to stress this, if they're unstable, it doesn't matter because it's the same treatment. It's going to be cardioversion. Okay? Understand that when I'm talking about this, I am talking about strictly if I have a stable patient. Okay? If I have a stable patient, in other words, do I have time to run a 12 lead? Remember, that's one of my little simple criteria. If the answer is anything but yes, I need to be putting on the pads and I need to be shocking the patient. Okay? So if they're unstable in any type of wide complex tachycardia and they're unstable, doesn't matter. They're getting electrocuted, okay? They're going to get a cardioversion. Now let's talk about machine logic here. If I look at this strip, I immediately realize that this is VTAC. All right? And I'm going to tell you my little... By the way, stuff that we've already learned, right? We've already learned that ventricular in origin, down, down, down. Ooh, ventricular in origin. Let's go up here. The axis, 241, huh? So if I do this is 180, that would be 270 or minus 90, whichever one you want to pick. But 240 is kind of that direction. So that's in no man's land. So we know, there is no doubt about it, by the way. By the way, there's the other little criteria you're about to learn, which is what we call down, 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 up. So the other one that I look at is V1. So if that's down, if that's down, if that's down, and this is up, I know that it's VTAC. But let's read of what the machine says it was. Atrial tachycardia with second-degree AV block, Moblitz type 2, nonspecific interventricular conduction block, right ventricular hypertrophy, inferior infarct, probably recent anterior lateral infarct, probably recent abnormal EKG. Yeah, the machine got it wrong. Okay? No, this is VTAC. There is no doubt it's VTAC. Why are we even remotely looking at it? But yet I know, and you guys have probably seen a few doctors read this right here. Okay? Guys, this is why we don't read. This is why you really don't want to read this stuff, okay? It's doing what it was trained to do, okay? It was doing what it was trained to do, but you are doing what you're trained to do, which is to make an informed decision because you know that down, down, down is ventricular in origin. You know that this right here is going, it's going from the ventricle up, up. That's the direction of travel. It's coming from the bottom of the ventricle towards back to that atrioventricular line. Yeah, this is VTAC. There's no doubt about it in the world, okay? So, again, so let's do, if the QRS is wider than 120, look at the axis criteria. Matter of fact, that's kind of the first thing that I do if I have a 12 lead, is look at the axis, okay? Because if I see that it's coming from no man's land, guess what? It's VTAC, all right? We're going to look at the morphology of V1 and V6, okay? We're going to look for concordance, and we're going to talk about what concordance is. And then, again, is AV dissociation present? And then, again, patient history and meds, definitely. If they've got a history of going into VTAC, well, we're going to think it is until further notice. All right. By the way, everybody, remember that little criteria I just used? I said the first criteria for VTAC. Lead 1 is down, lead 2 is down, lead 3 is down. And then V1, or modified chest lead, if it's 1, and it's going to be pointing up, okay? And that's the criteria that I use, down, 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 up, all right? 99% is probably VTAC. I'm good. I would be willing to very much take that bet in any gambling venture. If I had a 99% chance, I'm probably making that bet. All right? So here we go. Let's look at that. Oh man, I love it. Let's look at this undetermined rhythm here. Wow, you got to be suspected MI. Okay, well, of course the machine's right. Okay, abnormal right axis deviation, right bundle branch block, cannot rule out anterior infarct. Wow, you got to be kidding me. Let's see here. Let's look at the axis. 211. Remember on our little axis chart here. Yeah, well, 211's about this way. That's ventricular. Once again, we're in no man's land. Oh, well, here we go. Really simple. Down, 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 up. Down, down, down. V1 is looking up. By the way, V1 also has the fireman's helmet. We'll learn about that here in just a second. Okay, so, long and short. Yeah, it's wide, it's fast, it's regular, and it meets that criteria. Down, 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 up. VTAC. However, every now and then you get one that doesn't fit exactly that criteria, but I will tell you that it's 90% specific, and that's when you got down, up, up, down. All right? So, let's take another look at a slide here. Okay, well, once again, let's look at what the machine says it was. The machine said, the machine says, well, regular rhythm, right bundle branch block, left posterior. Okay. Well, it's regular. It's wide, it's fast. Okay. So this is down. Well, wait a minute. Oops, this is pointing up. This is pointing up. And this is pointing down. Okay. So, again, down, up, up, down. If you see that, it's probably VTAC. All right. And again, if I'm looking at that in lead 2, I'm probably saying, yep, VTAC. Now, the only other one that kind of doesn't fit the mold here is the 111, okay? So what's happening is you get the direction being this direction, okay? However, this is wide, it's fast, it's regular, and it's more than likely coming from the ventricle. The only difference is it's high up on the ventricle, and that's why it's conducting through in this manner, okay? That's why it's not conducting back through that, so that you understand where it's probably conducting from. But again, it's wide, it's fast, it's narrow. Down, again, down, up, up, down. Yep, good enough. We're going to get ready to take care of business. All right? All right, so look at your morphology, by the way. Look at V1's morphology. If it's got the peak, if it's got a twin peak, the left one is taller than the right one. If it's got a church steeple, or if it's got the fireman's hat. Remember I talked about the fireman's hat just that on that slide a couple back here. So if I've got any morphology clues here, especially in V1, okay, that it's a positive direction, more than likely, again, positive direction, and they've got one of these three here, again, it's probably going to be VTAC, all right? The other lead that you can look at, again, is if V1 has got a negative deflection, but it's got, again, the notch or the slur, okay? So it's kind of like the backwards of what we just saw right here, okay? So if you're seeing that, that's a pretty good clue that it's VTAC, all right? Usually your SVTs, they actually stay pretty consistent. The other thing you can look at is the V6 lead. And again, if it's predominantly negative deflection, it usually indicates a VTAC situation. All right. So this is the other clue that you're going to use as far as morphology. Now, so again, if I use the down, at that point I'm looking at this going as VFib, but this guy is up. Okay. All right. So that's the only one that doesn't fit the down, up category. But look at V6, guys, primarily down, okay? So if I really can't tell, V6 is probably a good indicator. Oop, yep, this is definitely, we're looking at that. The other thing is you got a really peak T wave here at this point. Again, patients, by the way, with your emphysema will have low voltage. So they've got the muscle changes, and so that's why this one kind of gets lost in the shuffle. But the good news is the other side's kind of bigger, and we can then see that this has got a negative deflection. Remember, V6 is usually the other direction when we're looking at the wall of the heart. So, concordance. All right, so it's another way to rule out if they're all up. By the way, it suggests it's suggestive of VTAC, but we got to make sure that it's not Wolff Parkinson White. And if they're all down, it suggests as a VTAC, and we got to make sure that they don't have a bundle branch block, okay? And that would be a left bundle branch block. And usually, by the way, a left bundle, gang, remember the left bundles usually go this direction, okay? So, because again, if I'm making the little triangle here, so you got to remember if you're seeing this, you got to make sure that you don't have a bundle branch block. Here, we just want to make sure we don't have Wolff Parkinson White, which would be a slurring wave. Check your lead 2 for a really narrow PR interval and that delta wave. Again, it's going to have that PR interval, but it's going to have that sloping delta wave, right? That's the guy right there. So double check those. But most of the time, if they have concordance, they're all in one direction. Very indicative. It's very suggestive of VTAC. So again, negative concordance. All 6 of these leads are pointing in the downward direction. Okay. By the way, if we weren't really sure, because I would say that this is down, but this one is down. But look at all of them are down. So at that point, I'd say, oh, yep, good enough. It's VTAC. All right. Now, the reason that people get kind of confused about that is because they're not really sure if it's coming from the atria or not. They see this little bump right here, and they're not really sure if that is a P wave. And in this case, if I look at these leads right here, I'm not seeing that P wave. That's why I'm thinking that this is VTAC. Okay. Again, positive concordance with with Wolff Parkinson White. You got the delta waves that are indicative. Again, this is a good example of a delta wave, by the way, and the short PR interval. Remember, in V1, by the way, or any of your ventricular leads, the P wave is probably going to be downward in those ventricular waves. So that is actually kind of a normal finding. Okay? Now, Afib. Here's the cool thing. If I take a look at this strip, it's irregular. Guys, VTAC is going to be regular. With one dumb exception to that, and that would be torsades. Torsades de points, right? That's the only time it's going to be irregular, all right? So this right here is the only reason. This is definitely not a torsade situation. All right, it's an irregular. This is a rate-dependent bundle branch block, all right? So the wide complex is formed during the tachycardia, okay? So long and the short is if it's irregular, it is probably not ventricular tachycardia, okay? Now, can we have a crazy beat involved with this? The answer to that is yes, you can have a funny little beat involved here. Okay? You can. But again, do I even see it here? I don't even see it on that one. But these guys here, I definitely do. So what's happening is you've got a dissociation, and it's trying to break through to go back to a normal rhythm. Unfortunately, this lower pacemaker has a rate that's faster, and it takes back over. So it's trying to actually correct itself. That's what you're seeing in this case. All right. So again, when you're talking to these patients, especially with VTAC, have you had a heart attack before? Did you have a fast heart rate after your MI? If yes to the both, there's a good chance that your wide complex tachycardia is more than likely VTAC. Okay, so all of these things play a factor in this. Okay, so what do I need to remember? That seems to be the question. Well, not a problem. Down, 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 up is probably a good one to remember, right? Down, 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 up. And up would be the V1, right? Down, up, up, down. That's VTAC. All right? If I've got any type of wave, the hat, again, the steeple, the hat, or the Twin Peaks, okay? Probably going to be VTAC in there. All right? Your concordance is all of these, the V leads pointing one direction or the other. Okay? All right. So take a look at these things. All of these things are indicative of ventricular tachycardia. Okay? I'm going to tell you right now, I don't think anybody's going to fault you if you start letting cases loose with this one. All right? So here we go. Let's take a look at this. All right? So again, by the way, look at my axis. Minus 81. Okay? So minus 81 on that little chart would be kind of this direction here. We're not in no man's land, so wait just a minute. Let's take a better look here. Now, if I'm looking at just this, I can pretty much tell you, yeah, VTAC, let's shock it. Okay, so we got up, down, down, down. Interesting. Now, how do I know that this is up or down? Look at where the point is versus the rounding there. I would say that the point down here is your down. So up, down, down, but this one's down, okay? But look at V6. V6 is, again, down, okay? It's a negative complex, all right? So again, V1, not really diagnostic, but V6, it's pointing down. Guys, V6 is almost always right side up, okay? Almost always. If I got a wide complex tachycardia and V6 is down, it's probably VTAC. Let's see here. Oh, look at this. Oh, look at this incredible. Look at this. Let's read that here. Sinus tach with sinus arrhythmia, non-specific intraventricular block. Oh yeah. Let's see here. Down, down, down. Okay. But we got V6 again. V6 is also a negative deflection. Okay. Let's see here. What's our axis here? 248. Let's see here. 248. That would be this right here. Oops. That's no man's land. Guess what? Yeah, this is VTAC. Yeah, great call, machine. Okay? This is why we don't look at that. All right? Oh, here we go. Another one. Undetermined rhythm. Abnormal right axis deviation. Very nice. Non-specific intraventricular block. Interesting. Okay. Probably an old, and it's definitely an abnormal EKG. Well, let's see here. Our little graph here says 256. Hey, guess where? We're in no man's land. But just for ha-has and hoes, down, down, down. Well, that one's down, but this is also the V6, also down. So guess what? Newsflash, boys and girls. Yeah, that's VTAC. All right? Let them have it. All right? Oh, I guess I should bring this up. So, if they got VTAC, again, our treatments is for unstable patients is to cardiovert them. I will tell you that Page's stance on that is all VTACs get cardioverted, whether or not they're stable or unstable. Before we electrocute somebody, though, again, we got time to administer medication because at the moment they're still quote unquote stable. I was able to do so again. 150 of amiodarone in a 100 bag, run it in at 100 drops a minute, 5 drops every 3 seconds, and then we give a lidocaine push. Long and the short here, though, real quick on that. Here's the problem with that. One of two things is going to happen, and it will happen, by the way, very quickly. Either you're going to almost instantly get a conversion with the medicine, or, which is 95% of the time, you're probably going to end up cardioverting. Guys, I think I've only had 2 in 30 years actually break with medicine, okay? If it was truly VTAC, and you started the amio or a lidocaine push or an amiodarone bolus, I can pretty much tell you within 3 minutes they went unstable, okay? Now, the good news is once they go unstable, it's all the same treatment. Let them have it, okay? Let's see here. Let's go back. Let's see here. Down. I'm not really sure. V6 is down, though. That one's up. Good enough for me, okay? Oh, yeah, by the way, the little mountain, big mountain, I would say we definitely have a steeple right there, okay? So, again, it should be a big mountain. How about this guy right here? Upright V1, so up, down, up. So up, down, up. Again, I'm going to look at the axis. The axis is actually minus 66, so that's kind of like over here. Oops, not really good there. All right, but look at V6 at that point. V6 is down. Oops, guess what? Bad news bears here, okay? Yeah, this is we got some dissociation here. Matter of fact, it actually tried to break through at this point. If you guys take a look at this right here, it was actually trying to break through, but it went right back into VTAC. So this is a really interesting case, actually. So again, this guy, he's in VTAC. Yeah, he's going to enjoy some high quality Versed, hopefully. Down, up. Interesting. Let's see here. Oh, wow, that kind of looks like a steeple. Not really good. Oh yeah, that's down. Yep, that's V. Oh, but let's see. Oh, wait a minute. We have a highly trained machine that's going to tell us what it is. Undetermined rhythm, right bundle branch block, lateral infarct, age undetermined, marked ST depression. This is VTAC, folks. All right. Wide QRS tachycardia, right bundle branch block. Well, at least he got that part right. Inferior age unknown, abnormal EKG. Yeah, let's see here. The axis is a 269. Yep, 269. Actually, it's probably more straight up than it is anything. Let's see here. Up, down, up. Guess what? Up, down, up. V6 is negative. Let them end. By the way, we had a peaked steeple here. Yeah, guess what, ladies and gentlemen? You get a lightning ride. All right. So hopefully you guys got to see definitely how that worked. Again, we're going to practice this a lot more in class. I know that I went through that kind of fast, but really important to understand. There is a difference the way we treat an SVT. If we got a true SVT, then we just need to slow down. Again, we usually use cardizem if they're stable, okay? Or we use adenosine to try to figure out whether we need to break it or not. A ventricular tachycardia, we need a ventricular antidysrhythmic, okay? We don't need anything that's going to work on the top part of the heart. We got to have a ventricular antidysrhythmic, okay? So diagnosing this correctly is essential, and it's one of the things that you're going to be doing when I put a 12 lead in front of you is a couple of the questions you're going to ask yourself. Is this VTAC? Is this a bundle branch block? Okay. And then diagnose whether you got any ST changes. All right. So there's more than one use for a 12 lead, and that's what we're going to be practicing. Okay. Guys, I'm going to see y'all in the next video.